Good evening, everyone. A very warm welcome to all of you joining us today. I am Dr. Vaishnavi from the team of Voice of Healthcare, and it's my privilege to welcome you all to this special World Cancer Day 2026 virtual panel discussion titling Bridging the Access Gap in Breast Cancer Care Early Detection to Treatment. This session is organized by Voice of Healthcare and is supported by Alchem Laboratories Limited. The discussion has been designed in a way that we dwell in depth about breast cancer in India. So, before we begin this discussion, it is important to briefly set the context around breast cancer in India and why this conversation is important. Breast cancer has emerged as the most commonly diagnosed cancer among women in India, contributing significantly to cancer related morbidity and mortality. While medical advances ranging from improved imaging to targeted and precision therapies have transformed breast cancer care globally, these benefits are not reaching all patients equally. A large portion of women in India continue to present with locally advanced or metastatic disease. Delays often occur due to limited awareness, low screening uptake, social stigma, financial constraint, and fragmented referral pathways. At the same time, India has made important strides through National Cancer Control Initiative, expanded insurance coverage, and public-private collaboration. However, implementation gap at the primary and secondary care level continue to limit their impact on breast cancer care outcome. So, with this context, we are truly privileged to be joined by a distinguished panel of experts Dr. Jyoti Wadhwa, Lead Medical Oncology and Precision Oncology, Apollo Athenaa Women's Cancer Center. Welcome to the session, Dr. Jyoti.
Thank you.
Colonel Ajai Tomar, Chief Executive Officer, Indian Cancer Society. Welcome to the session. Dr. Shyam Aggarwal, Senior Consultant, Medical Oncology, Sir Ganga Ram Hospital, New Delhi. He'll be joining us shortly. Dr. Shona Nag, Director of Oncology and Senior Consultant, Medical Oncologist, Shayadri Group of Hospitals, Pune. Welcome to the session, Dr. Shona.
Thank you so much.
Dr. K. Madan Gopal, Senior Health Sector Expert, former Senior Consultant, Niti Aayog, Advisor, National Health System Resource Center. Welcome to the session, Dr. Madan.
How can I get
So, thank you for being part of this important dialogue. To set this conversation forward, my first question is to you, Dr. Jyoti, that how has the breast cancer burden in India evolved in terms of incidence, stage at diagnosis, molecular subtype, and how do precision oncology approaches influence outcomes amid existing access gaps?
Right. Breast cancer, in fact, is the most common cancer amongst Indian women, as you mentioned in the introduction yourself. And it has, for many years now, surpassed cervical cancer, which earlier used to be the number one cancer affecting women in India. So, if we talk of the most recent Globocan data, Globocan 2022 data, breast cancer cases in women in India account for almost 27% of the total number of cases affecting women. And the numbers are increasing. So, just to give context to in terms of the numbers, in 2022 itself, the breast cancer cases newly diagnosed in India were to the tune of 1,90,000 or so approximately. And this number continues to increase year by year. Now, furthermore, in India, breast cancer patients often present in advanced stages. Most of our patients still, say 60 to 70% of them, still present to us in stage 3 and 4. And obviously, this is due to the low level of awareness and the absence of mass screening policy in India. Now, furthermore, the breast cancer that we see in India, if we subtype it, say on the basic tests like hormone receptor, the HER2 receptor testing, we can classify them into various subtypes. And one of those subtypes is called the triple negative breast cancer. This is the most aggressive subtype of breast cancer. And in India, we see a greater proportion of triple negative breast cancers when we compare it to the West. So these are some of the peculiarities that we encounter in our Indian women suffering with breast cancer. Now, the last bit, what you asked was the precision oncology approaches. So we have, in terms of cancer treatments, we now practice precision oncology, a part of precision medicine, and the aim is basically to improve the outcomes. So if we talk of the precision oncology approaches in breast cancer, so it's not really new, because the hormone therapy itself for hormone receptor positive breast cancer is a type of precision oncology itself. So the it has been there, but it has become more refined, and the scope has increased tremendously in recent years. And obviously it does improve the outcomes, but the precision oncology, the way it is practiced in 2026, is hampered. The utility is hampered still in India by its high cost and limited access. So that gap, that's a huge gap that continues to remain unfilled or unfulfilled, I would say.
So, thank you so much for highlighting that gap and taking my conversation forward. My next question is to you, Dr. Shona, that what are the major barriers to early detection and screening uptake, particularly in the semi-urban and rural regions, and how can community awareness and primary care sensitization improve these early referrals?
So I think that's an excellent question, and we have been struggling in India with this for a very long time. You must understand that our population is too large to enable a mass mammography effort. And so far, mammography and to some extent sonography and MRI have been the only correct ways or accurate ways to pick up early breast cancer. Uh, the cost, the lack of radiologists, the fear surrounding the breast cancer diagnosis makes mammography not only impossible to do everywhere, but a very, very expensive tool, which is very labor intensive. So there have been other ways that people have tried to bridge this gap. And one has been the thermography method, but one must remember India is a hot country. Until the patient is a cool temperature, you can't get that contrast in temperature, which is then used to diagnose abnormal signals and pick up abnormal lumps. The other effort that the government of India has made is towards this handheld device, which is called iBreast, which relies on these pico crystals, which then pick up any abnormalities. But then again, you have operators who are not perfectly trained on this, and you get a lot of false positives and lot of false negatives. So screening is really not an option for us. What we can do is simple things like encourage self-breast exam, which goes a long way in women right from the age of 20 to the age of 80 to know what their normal is. We don't expect women to diagnose themselves with breast cancer, but just to know when something is obviously wrong earlier rather than later. The other thing they could do is a simple clinical breast exam with a professional once a year, once you reach 20, right up to your later ages, especially if they don't have access to specialists. So, this is something that can be done. And there is a Tata study to show that clinical exam, which was done in the slums of Mumbai, brought down the tumor size from 7 centimeters to 4 centimeters. So that is small steps, but it's a way to get there. Awareness, again, I will keep stressing, is very important. We need to decentralize. Our doctors are certainly not going to go out into the periphery. We need to kind of empower and enable primary health centers and general practitioners living in the periphery and semi urban and rural rural areas, to teach them clinical breast exam, to even teach Anganwadi workers. And our foundation has done some work on this, where we still have patients after 5 years of training the Anganwadi workers to do breast exam on models. They are still referring patients to us that they are finding with lumps. So these kind of small steps will go a long way in getting some sort of screening taking place in our country.
Correct. So we have Dr. Shyam Aggarwal. He has also joined us. Thank you so much for joining, sir. I'll quickly take up your question since it was pending. So, from your clinical experience, what are the key world challenges between diagnosis, treatment initiation, and how do outcomes differ between early stage and advanced stage breast cancer presentation?
Absolutely. I think, Dr. Vaishnavi, these are very pertinent questions. So, one thing is to diagnose breast cancer early. We need to do annual or at least once in 2 years mammograms after the age of 45 years. But unfortunately, in our country, only 2% of the women do that, and that too only even in metro, big cities. This is opposed to the fact that in the US, 70 to 80% women will do annual mammograms after the age of 45 years. And in Europe, maybe 60, 70%. So there's a huge gap which needs to be filled up, to encourage women to come out for doing mammograms periodically as, per guidelines in international and even national. The second thing why women are not forthcoming are it starts as a painless lump, and sometimes deliberately or otherwise ignored. I mean, if I have a breast cancer, then the surgeon is going to put a knife there, and that is what is not liked by a lot of women. So I think the scare of the word breast cancer also puts them off for going to the doctor, whether it is a gynecologist or a local surgeon. And the third thing I'd like to say that even when they go to a doctor and a mammogram is done or an ultrasound is done and physical examination has occurred, when they advise for a biopsy, there is so much of scare and a mindset that
I think there is some network issue at Dr. Sham's end. So I'll quickly take the next question to you, Colonel Ajay, that from a from a civil society and NGO perspective, how critical care, community-based screening initiatives, and patient navigation and survivorship support in is improving early diagnosis and follow-ups.
Again, a very interesting question. Now, what happens is that women, especially in the rural and the unorganized sector, that is settlements and all, and semi-urban area, they do not go to the fixed facilities. The government offers fixed facilities at PHCs and hospitals, but they don't want to go there because of distance, because of fear. Like my previous speakers had said, they don't want to. Move out of their comfort zone. So here is where the NGO step in. Like my NGO, Indian Cancer Society, we have got doctors and we have got vans and volunteers who reach out to these people. They move in special vans equipped with mammograms, with X-rays, with blood testing equipment, everything, and we move to their doorsteps. So that fear and before we move, we carry out an awareness campaign in that area. We have got volunteers working, then we have got connections with the Asha workers, Anganwadis. So we carry out an intensive campaign. We distribute leaflets. We have got a mobile app also on which we give awareness about various types of cancers, especially breast, cervical, lung cancer. and gynae cancers.
Why do you make me for this?
We reach out, they feel secure. Okay, some reputed people are going to come and do the screening. Awareness, we empower them with self breast examination. We give them leaflets. Our trainers, they train them also. Only after that, we move with our screening vehicles to that place. So once we move there, so we have now bridged that gap. Government facilities are fixed. We move on. We move to their doorsteps. We allay their fears through awareness. We do screening at their doorsteps so that distance problem is sorted out. We do it free of cost. Even mammograms we do free of cost. So they are not worried about the cost factor. And once what happens, if something comes out, like previous speakers were saying, they're scared ki ab kya hoga. So we go and do their diagnostics also free of cost. So screening alone does not serve the purpose. It won't solve the cancer problem. However, diagnostics and then care, continuum of cancer care, that we ensure that whoever comes out through our screening, we take them, we handhold them and take them right up to the tertiary hospitals if required. And I won't be covering cervical cancer, but just for information, we see and treat cervical cancer also. So that is how NGOs they step in where there are gaps in the government organizations. So civil societies should not be looked at with suspicion by private partners and all, like PPP model, which we'll be talking later on. So there's always a doubt कि ये क्या कर रहे हैं. Industry people think कि NGOs are just bluffing. The government says they are just trying to extract money. It is not so. We all have to work in unison. Then only we'll gain confidence amongst the public. And like Dr. Jyoti had said, vast population, it's very difficult to cover, but as NGOs and small societies, we try to do our best. Thank you.
Okay. So, thank you for explaining it to us and bringing that point forward. My next question is to you, Dr. Madan, that how do existing national programs address breast screening, breast cancer screening, diagnosis, and treatment access across different levels of care in India?
Vaishnavi, thanks. I think I'm audible. Okay.
Yes,
Yes.
yes.
Okay, okay, that's fine. So this question is very relevant because many of us, many of the general public, they are not aware what are the efforts which are being made by the government of India and what the government is trying to address this issue of breast cancer. We do have a tiered public health system, which what we are doing is we are doing a population-based screening. Based on that, we are doing a referral. We do have a referral mechanism as well as some financial protection is there. We are having a tired public health system which is trying to address these issues. What I meant by this tired public health system, that means we are having the primary, secondary, and tertiary, which all know. I am not going to details of that. We have around 1,82,000 this sub-health center, which are now known as Ayushman Arogya Mandir, Ayushman Arogya Kendra, and the different nomenclatures are there in different states. Here comes the a person is assigned there the who's a trained nurse. The nurse usually handles and they do the population-based screening based on the checklist and other things. The population-based screening starts from there. Despite having a huge network uh, to complement the efforts of this 1,82,000 facilities, we have having an army of ASHA workers, which are more than a million. And through them, the population-based screening is being attempted. That means they are helping in doing the population-based screening. After they are screened, we have a mechanism in which the community health officer, who is known as the community health officer at that level, they can use the telemedicine services, the eSanjeevani platform, which is there, so that a structured referral protocol is there. I'm giving you the structure. I'm not saying how much 100% is working or not. I'm not claiming that. I'm just saying that this is a structure which is there. That means on the structural referral aspect also, mechanism is there. We tried that we are having more than 30 crore teleconsultation, but still the challenge is that the screening is not happening. That means breast cancer screening is not uniform. Apart from that, there are many state government schemes as well as PMJ, which offers the treatment for cancers. It's not that it's not there. So if you apart from that, we were the first to start the national program for non-communicable disease. Previously, it was as cancer, diabetes, and other thing. Now, the simple name is the National Program for Non-Communicable Disease. This is a platform which has been created. This program is a platform to promote awareness, risk assessment, and early identification from the frontline teams. Apart from that, strengthening the secondary care system for treatment of this cancer patient. The focus not only the screening but also triaging symptoms early so that by doing the clinical best examination wherever appropriate, the, the close referral can happen. Many of the states they have taken clue from that. They have tried to rope in the tertiary care institution, medical colleges. The moment their population is screened, they are referred to they are repaired and put to treatment at the particular place after doing the required test and diagnostics, whatever is required. And after doing that, if you look at the budget announcement last year, what has happened is it was announced to have a daycare cancer centers at all the district hospitals. We do have around 780 plus districts. And each of the districts is having a district health institution. In that institution, they are having a daycare, which can act as a hub and spoke. That means the hub could be a tertiary care institution, and they can do the continual of care of these cancer patients. And that mechanism is there, it is evolving, and it is there. Apart from that, at the secondary level also, if you look at the community health center, the sub-district hospitals, we have recently reviewed the first referral unit guidelines, which includes the diagnostic confirmation pathway. That means the patients who are coming from the health and wellness centers or the primary health center, they can be diagnosed at this. Apart from that, if you look at the national diagnostic list, it talks about the markers at the integrated public health labs, which would be there at all the public health institutions. At the tertiary level, medical colleges are there, which are providing definitive management, surgery, chemotherapy, radiotherapy, with the multidisciplinary teams which are there. For the financial protection and affordability, the Pradhan Mantri Jan Arogya Yojana is there, and the state schemes are there which supports the treatment cost. And the public systems also work through free low-cost services and programs linked referrals. I don't agree with my previous colleague that we don't trust. We trust all people because nowadays a new terminology is being used for PPP partnership. That is a partnership for provisioning care. So we look forward to that kind of partnership when whoever is trying to continue that so that we can ensure a continuum of care as well as early identification of the patient and other things. There would be some exception that the people previously they never used to. They say that they would be only now that notion is slowly and slowly changing. See that if somebody is very serious in doing some work, they are getting recognized and they are contributing to the other things. Apart from that, the national program which we are trying to address the cancer to a target pathway, we are also having investments into the this primary care platform for early diagnosis and referral, which I have already mentioned. The priority of the program is to make a time-bound time-bound identification as well as a predictable referral, so that early diagnosis and treatment, which you usually talk about, that becomes a reality. I will stop here, and when the next question comes, I will be able to give my response. Thank you.
Correct. Correct. So, since we are discussing about early detections and all of that, so my next question is to you, Dr. Jyoti, that what role can risk-based screening and newer diagnostic tools play in the Indian context, and how scalable and feasible are these approaches across healthcare setting?
Yeah, so Dr. Shona alluded to this briefly, and I want to reiterate that keeping in view the breast cancer epidemiology in India, one size will not fit all, and this is applicable to the screening approaches also. So we have to remember that we deal with much greater proportion of younger patients, higher proportion of aggressive subtypes, namely triple negative breast cancer, as I mentioned. There is low population level mammography coverage due to mainly financial reasons, as Dr. Shona said, and the lack of expertise. And there's a great urban rural divide and a lot of public private disparity. So we can't forget the realities, the stark realities that we have in Indian subcontinent. The risk-based screening therefore becomes especially relevant for India, I feel. If we could identify women who would benefit most from these screening modalities, from the earlier screening modalities, we should focus on them. We would therefore end up avoiding over screening the low risk women, and we'll be able to shift our focus to high risk population of women. And this would enable shifting of the disease stage from presentation at stage 3 4 to stage 1 and 2, and that will be a big achievement. However, the breast self examination and clinical breast examination, I feel, continue to remain relevant in India because of all these reasons. I feel that breast self examination should not be ignored. And as Dr. Shona was mentioning, that starting at the age of 20, the women need to become breast aware so that they themselves can report any odd feature, any abnormality earliest. So, breast self exam and clinical breast exam can't be ignored in Indian context. Now we have these high tech diagnostic tools or screening tests like MRI. We are also seeing greater use of AI assisted imaging, which though is available only in a select few centers. So these, whenever feasible or whenever indicated, could be offered to selective group of high risk women. But for a vast majority, breast self exam, clinical breast exam, mammography, with or without ultrasound as the need be, because we deal with younger patients, they remain relevant. But these high tech modalities could be offered to a very select few. And therefore, I think in India, what we need is a risk based tiered screening approach, I would say, rather than a blanket mammography for all above 40, or like what they have in West. So we have to tailor make our own screening approach. And we must not forget the significance and relevance of breast self exam and clinical breast exam.
Correct. So thank you for highlighting that point, and I believe we have specific stakeholders here who can take this word and spread it across and work on it. So my next question is to you, Dr. Shyam, that what systemic gaps, diagnostics, affordability, referral pathway, or follow-up most significantly contribute to treatment delays, and how can multidisciplinary and integrated care models strengthen these gaps?
So I think in any cancer, including breast cancer, multidisciplinary approach is very important, in which we have the surgeon, we have the radiation oncologist, we have the medical oncologist, and in this day and era, we also need to engage with the palliative and the supportive care groups so as to ensure the best delivery of the treatment which we are planning for a given patient. So, I mean, unless you have these three, pillars of cancer treatment, you'll not be able to deliver the best. And we need to also understand there is a regular evolution in the treatment of breast cancer over the years. For example, if you're focused on early breast cancer, today, if somebody has a 2 or a 3 centimeter tumor in the breast, which is triple negative or HER2 positive, unlike earlier, where surgery was the initial treatment, there is a paradigm shift that we are talking about, chemo with the HER2 targeting or chemo with immune checkpoint inhibitor in triple negative. So, I mean, unless the team which is involved in the care of a patient is abreast with the latest developments, you'll not be able to deliver the best. So that's, of course, number one. We need to have access to the investigative tools in order to decide, for example, the estrogen receptor, progesterone receptor, HER2/neu, Ki67. And now, of course, in the era of genomics, we need to have access to those as well. So cost does come in the way in managing, patients with breast cancer, because some of these HER2 targeted drugs and immune checkpoint inhibitors are extremely, extremely expensive. But then there's a need for having support groups to perhaps fund. We do have, PMJY, I mean, the Ayushman. We do have funds from Prime Minister, from Chief Minister funds. So, I mean, finances do become an issue when you talk of specialized treatments. And of course, in a country like India, where finances are, are a constraint, there is an issue of supporting the family, which is, left behind. Because some of these women are young and they are looking at long-term treatments for metastatic disease. And today, even advanced breast cancer has been converted into a chronic disease. So there is a regular drain month after month, year after year, because the survivorship has increased. So, there's a need to counsel these patients. There's a need for encouraging people to enroll in the insurance programs so as to, if they are hit by this disease, they have the support, financial support from financial programs. So there is a huge unmet need by and large to take care of all the patients who are diagnosed with cancer. But I think a multidisciplinary approach with the supportive care is, I think, need of the hour.
Correct. My next question is to you, Dr. Shona, that how do breast cancer treatment pathway differ between tier 1 and tier 2 or 3 cities, and what practical regional level interventions can improve continuity of care? So
I
you're
think
on mute.
that's a very, very good question. And I think it's very important as well because there has to be a way to translate the kind of expertise that we have in our tier one cities to the tier two and tier three cities. So, in the tier one cities, in most big institutes, private hospitals, we all follow in breast cancer care something known as a multimodality approach, where we are talking to our surgeons, medical oncologists, surgeons, radiation oncologists, and we kind of come up with the best format for that particular patient. We follow guidelines. We have Asian guidelines, we have European guidelines, we have our own Indian guidelines by the ISMPO. In fact, Dr. Aggarwal has written a very nice set of guidelines for our ISMPO. So we do follow these guidelines when we are treating patients. All patients may not fit in a conventional box, so then you need to think a little outside the box as well. But there have been a lot of shifts. A lot of our patients come with slightly advanced disease, larger tumors, more lymph nodes in the armpit. So we prefer to give chemo or targeted therapy or immunotherapy first. We want to shrink it, we want to improve the outcomes, we want to assess the response to treatment so that we can rescue the patient, so to speak, if we haven't been able to get rid of all the tumor with other drugs. So there's a lot that's happening out there. And in a tier one city, it's possible to find a geneticist, it's possible to get a fertility expert, especially if there's a young patient, freeze the embryo so that she has a chance at a normal life after the treatment is over. And this is not always readily available in tier two and tier three cities. Sophisticated imaging, sophisticated surgical techniques, radiation techniques are not very, very well practiced in the periphery. So, this is an ongoing challenge, and one way of overcoming it is not to bring the patient to a tertiary center for each and everything, to kind of divide the more skilled approaches, like, for example, a complicated surgery, a reconstruction that could be done in a tier one, but basic chemotherapy, hormonal therapy, and a good linear accelerator would take care of the treatment in the tier two city. So, to have contact with various hospitals, to reach out to the referring doctors from tier two and tier three, enabling them to communicate with us regarding the management, and perhaps have specialists really visit those tier two and tier three cities. These are some ways in which we can close the gap. We also run a lot of training workshops online and pass on this education through ISMPO, through our foundation, and through various institutes. So, this is something that is ongoing.
Correct. So since we are talking about how can we maybe intervene into these tier 2 and tier 3 cities also. So my next question is to you, Dr. Madan, that what are the key implementation gaps at the primary and secondary care levels, and how can public private partnership be strengthened?
Vaishnavi, thanks. The biggest gap is not the policy intent, which you see. We do have a strong national program. The national policy is there. We do have financial protection mechanisms. All the ecosystem is there. But the biggest gap is the execution of this pathway. Okay, I will just elaborate on at the primary care level what are the gaps. One of the important things which has been echoed by the other panelists is low awareness and the stigma associated with this. As a result, the women's present late. That's we got one of the biggest gap which we are finding. Despite having a network of so many people, having IPC, interpersonal communications, and a different mechanism, but still this one of the biggest challenge. Apart from that, the other gap is the variable skills and the confidence for symptom recognition. Because though we are training all the people, there's a confidence even among the medical officers. There's a confidence for symptom recognition and clinical best examination is more or less an area where a lot of work is required to be done. And beside that, even after the primary screening, one of the important gaps which we are facing is the weak tracking of the women. Because women who screen positive or have symptoms are not always close to diagnosis. They need to be put to some or connected to some institution so that regular follow-up can happen. Besides that, limited patient navigation support for travel, appointments, and follow-up. You see that the catastrophe which a cancer patient brought to the family, it's all well known. If you come to the secondary level, the gaps are more operational, operational gaps. Though we have invested into the block public health laboratories, but still diagnostic bottlenecks are there. Imaging, uh, even the imaging facilities, even if they are there, either they would be having some logistics issue or other things. Besides that, we are having around uh, uh, 7,000 blocks are there. So each block is having a community health center, and we are planning that each of the community health center would be attached to a block public health unit or block public health lab. But the biopsy arrangement, the pathology, and the integrated health turnout time is more or less quite debatable. Apart from that, it's a referral mechanism which we are having that is also very fragmented, and the patients either move between facilities without a single documented pathway. It's a no single pathway. Either a person living in a village, he can directly go to AIMS or to a high-end oncologist at a tier one city. Besides that, the coordination between the teams, because it is a multidisciplinary efforts. The coordinated effort is one of the important area where a lot of. Apart from that, the other thing is delay in starting the treatment after the diagnosis. That's why this daycare cancer centers, a network of all the cancer things are coming up in the government system. Apart from that, talking about the public-private partnership, these partnerships are there. It has to be a win-win for both the parties. It's a partnership for public provisioning. It's not a public-private partnership where the commonly it is felt that it is a profit-making venture. No, it's a partnership for public provisioning. The government, they can bring in the research and development as well as the high-end diagnostics and high-end treatment, and the public sector can bring in the screening as well as offering the ways in the form of spokes and other things so that different referral pathways can be created. Besides that, this public-private PPP models, they can at least augment the diagnostic capacities. A lot of models are there. The mammography, UGC access, the ultrasonography access, as well as biopsy and other things. They are happening with the help of this, with a defined turnaround times. This kind of MOUs are already there for so that the diagnostic capacity of the public institutions is also getting augmented. Apart from that, they are also helping the PPP models in some of the states. They are also helping in patient navigation. That means having a callback mechanism. Besides that, the treatment schedulers and other things that when the daycare cancer centers are opening, this is also been factored in. The hub and spoke is already been a quite well established mechanism wherein the district and the tertiary level institutions with tele-oncology for case detection and other things are happening. Other thing, the private partners and public partners can help us in providing a quality of care and reporting of all these things. They can come out with standard protocols, outcome reporting, and reporting back to the public. That kind of thing can happen. In short, we can have an accountable uh, partnership model for reducing time to diagnosis and time to treatment, because that's the major challenge which I've highlighted. The primary gap is, again, on to reiterate, is the awareness, skill variability, and follow-up tracking. At the Apart from that, at the secondary level, secondary gaps are the diagnostics, pathology details, and broken referrals. In short, the PPP, if we can focus on, it can help us in reducing the diagnostic turnaround time, can help in the patient navigation, as well as help us in the hub and spoke oncology linkages, which are there, which are few successful models are there. They can help us in further upscaling this model so that it becomes a clear quality and a quality of oncological services and can improve the reporting purpose. I stop here. Thank you.
Correct. So, thank you for explaining it to us so elaborately. My next question is to you, Colonel Ajay. That how can NGOs, foundation, and industry partners complement government programs to improve last mile access, patient awareness, and treatment adherence? Sir, you're on mute. If you can just unmute.
Sorry, I was muted. So Dr. Madan Gopal has already brought out all the good plans of the government, and he gave so many statistics. So we are very much encouraged by his talk as to how we can, as NGOs and civil organizations, go and bridge the gap. So what I could make out, the major gaps are regarding the awareness, the screening, and the patient navigation. So what we can do as NGOs, which we are doing also, I have already spoken about awareness and screening, so I won't cover that to save time. The third unit which we have is of rehabilitation. In rehabilitation unit, we have got large number of volunteers, those who are cancer survivors or those who are caregivers or who had been caregivers. They go to various hospitals and contact the patients. We have a regular visiting time and MOUs signed with few hospitals, private as well as government, where we go, and these navigators, they help the patients. Even they don't know which window to go. They don't know after this where to go. They don't have money for diagnostics. So we provide money for diagnostics. So to speed up, that was one more gap which Dr. Madan Gopal had said, that there is too much of gap and too much of lead time between screening, diagnosis, and treatment. And once the treatment starts, we ensure that they are handheld and taken through the whole process of continuum of care. We have that rehab center where those mastectomy patients, they are chai pe charcha type. They come there, they meet, they are given emotional support, and also lymphopress machines are there where in which they can reduce their pain. Now, regarding the private public partnership, I won't cover that much. Dr. Madan Gopal has already covered in detail. So, I had said that suspicion. So, I think that suspicion is very much reduced now because of the various initiatives being taken by the Ministry of Health and Family Welfare. And we would like to get embedded somewhere. So, there is more such type of panel discussions and meetings with the government, which will show us a way as to how we can fit in these population based screenings which are going on, and what where all we can help. So there's a requirement to mesh the civil societies or the civil societies and the NGOs into the whole overall plan of reducing cancer burden in India. So that's all what I wanted to say.
Yeah. So now, since we are moving towards concluding this session, my question is to all three of you: that what are the top two or three actionable clinical, policy, or system level interventions that could significantly improve breast cancer care outcomes in India over the next 5 years? So, Dr. Jyoti, you can go first.
So I think if we are looking at near future, you said next 5 years. So if we shift our focus to two areas, I believe. The first being early diagnosis of breast cancer by increasing awareness, by offering those uh, diagnostic tests to each and every individual, and making this basic testing, estrogen receptor, progesterone receptor, HER2 new testing, non negotiable and should be reimbursed under all public schemes. So if we do this first step, we'll enable early diagnosis, and hence the stage at diagnosis would shift. I keep saying that's the most important step that should be looked at. If we shift the stage from 3 and 4 to 1 and 2, the outcomes will automatically improve. The other thing, if we could ensure, through policies, if we could ensure access to the essential breast cancer drugs, be it the hormone treatment, the endocrine treatment, or targeted drugs like trastuzumab. We now have biosimilars also come in, which are a great option for a vast majority of our patients. So if we could make these essential breast cancer drugs accessible to all our patients, I think that would be great. So early diagnosis and access to all the essential breast anti-cancer drugs, these are, according to me, two most important actionable steps that could improve breast cancer outcomes over the next 5 years in India.
So I would like to hear from you, Dr. Madan, that what is your perspective on this point? Am I audible?
Sorry. If you want to have a visible improvement in 5 years, we should prioritize three actionable systemic interventions. One intervention my previous speaker has already mentioned, the time-bound diagnostic pathways at the district level. We have to create a clear protocol that any woman with symptoms of positive screening results reach a diagnostic confirmation, which is delayed nowadays within a defined time limit and the time window. Otherwise, what will happen that there will
Oh, I believe his it is because of the internet he dropped off from the call. So, Colonel Ajay, you can go and share your perspective on like top two or three actionable points which should be taken care in the next 5 years.
Top two, I'll say, is firstly increase awareness pan India by whatever means is possible, using radio, using mobile labs, ABHA, whatnot. Awareness is first and foremost. If awareness is there, then screening will come. And once screening is done, then diagnostics, like, it's very important. Unless diagnosed, nothing works thereafter. Diagnosed, then treatment will follow. That's my take.
Correct.
Thank
So
you.
I would like to thank each one of you for making out time and joining this session, and spreading out awareness on breast cancer, which is one of the very prevalent topic in the Indian healthcare landscape these days. So thank you so much for joining and sharing your insights in the session. Thank you so much.
Thank you.
Thank you.